Hi guys, the topic for today is obstructive sleep apnea. So what is obstructive sleep apnea? According to the American Academy of the Sleep Medicine, AASM, obstructive sleep apnea is characterized by repetitive episodes of complete or partial upper airway obstruction during the sleep. Sleep disorders characterized by the recurrent episodes of narrowing or collapsing of the pharyngeal airway during the sleep despite the ongoing breathing efforts. Here you can see this is a tongue. So the tongue is falling back and leading to upper airway obstruction. So leading to apnea or hypopnea. The 2007 AASM diagnostic criterion definition. What is apnea? It is defined as a drop in a peak airflow of greater than 90% of the baseline for 10 seconds. More important is for 10 seconds or longer, and at least 90% of the event duration meets the amplitude reduction. Then what is obstructive apnea is defined as a continued or increased inspiratory effort throughout the entire period of the absent flow. And what is the mixed apnea? It is a ventilatory effort is not observed initially, the central apneic component, but the ventilatory effort follows, that is the obstructive apnea component. Now here you can see what happens basically. This is a sleep onset occurs first, then the upper airway collapse occurs, then the apnea-hypopnea occurs, hypoventilation, hypoxemia, hypercapnia, increase in carbon dioxide, decrease in oxygen, hypoventilation, then lead to pulmonary hypertension, and then lead to pulmonary hypertension. Here what happens? Apnea, hypopnea, then the patient arouse from the sleep. There is an increase in catecholamines leading to systemic hypertension. And here sleep fragmentation, daytime sleepiness, because the sleep is not complete because of the incomplete sleep and arousal in between. So patient will have deep daytime sleepiness, impaired cognitive function in memory, and a quality of life. So obstructive sleep apnea is largely undiagnosed epidemic, but need to understand it that 18 million suffer. Prevalence is similar to diabetes. So the 85% have not been diagnosed. So what we see, the tip of the iceberg. So here we can see that 1 million of Americans diabetes is, we can see here, but this is diagnosed, and this is OSA, obstructive sleep apnea, which is only a very small percentage is diagnosed, and about 85% which have not been diagnosed. So now let us talk about the risk factors. So risk factor can be mainly divided into anatomical factors, the neuromuscular factors, the nasal factors, the retropalatal obstruction or the retroglossal obstruction. There are so many structural factors. So when we talk about the anatomical factors like enlarged tonsils in children, volume of the tongue, the soft tissue and the lateral pharyngeal walls, the length of the soft palate, the abnormal positioning of the maxilla and the mandible. In the neuromuscular factors, there can be a decreased neurovascular activity in the upper airway, with a reduced ventilatory motor output to the upper airway muscles. In a nasal obstruction, there can be a polyp in the nose, there can be a septal deviation, tumor, trauma, or a stenosis. In the retropalatal obstruction, there can be elongated posteriorly placed palate or uvula, leading to obstruction. There can be a tonsil or adenoid hypertrophy. At the retroglossal obstruction, there can be a macroglossula, enlarged tongue, or a tumor. Well, in the structural factors, there can be a retrognathia or the micrograthia. What is that retrognathia? It is basically a posteriorly placed maxilla the posteriorly placed mandible as compared to the maxilla. The abnormal mandible, or the micro, it is a smaller size mandible as compared to the maxilla. So mandibular hypoplasia or a brachycephalic head, the inferior displacement of the hyoid. So these factors are the structural factors. Then comes the non-structural risk factor like the obesity and the central fat distribution. So males are mostly affected more than the females. It's a ratio of 2:1. And the post-menopausal state, alcohol and smoking, this also leads to OSA as a risk factor. Then comes the diagnosis. Well, history is a very important in diagnosing the nocturnal symptoms like snoring, usually loud, habitual, and bothersome to others. So patient usually come with these symptoms to the OPD. Then witnessed apneas, which often interrupts the snoring and ends with a snort. The gasping and choking sensation that arouse the patient from the sleep. There can be nocturia, insomnia, restless sleep. The patient often experiences the frequent arousals and tossing or turning during the night. So these are very important points as respect to the diagnosing obstructive sleep apnea. Then come the daytime symptoms like the non-restorative sleep, waking up as tired, morning headaches, dry or sore throat, excessive daytime sleepiness that usually begins during the activities like reading, watching television. As the severity worsens, the patient begin to feel sleepy during the activities that generally requires alertness like school, working and driving. There is a daytime fatigue and tiredness. And the cognitive deficit like the memory and intellectual impairment. Then comes the physical examination. In the physical examination, like obesity, we can check for the obesity. Examination of the obesity like body mass index (BMI) greater than 30 kilogram per meter square is obesity, and a large neck circumference greater than 17 inches in men and 15 inches in women. Abnormal increased Mallampatti scoring. And narrowing of the lateral airway walls and the enlarged torsals, retrognathia and the micrognathia, high arched palates, hard palate. So here you can see the Mallampatti classification. The first you can see the posterior pharyngeal wall, the uvula, the soft palate. In the second you can see the uvula but not, and in the fourth you can't even see this posterior pharyngeal wall and the uvula. It's completely blocking. So these are the Friedman staging system, which take into account the Mallampatti class, the tonsil size, the morbid obesity. So accordingly take the success rate. So indices for the sleep disordered breathing. The indices for the sleep disordered breathing are the AHI, apnea-hypopnea index. The AHI is defined as the average number of episodes of apnea and hypopnea per hour. So for the mild it is 5 to 15 events per hour of sleep. Moderate is 15 to 30 events per hour of sleep, and severe is greater than 30 events per hour of sleep. This is AHI. Then comes the RDI. What is RDI? It is respiratory disturbance index. Defined as the average number of respiratory disturbance, obstructive apnea, hypopnea and respiratory event related arousals per hour. So the diagnosis is combined assessment of the clinical features and objective sleep study data. So the gold standard is the overnight polysomnogram. The polysomnogram, it's provided detailed information on sleep state, respiratory and the gas exchange abnormalities. So the polysomnogram, it's a simultaneous recording of the multiple physiological signals during sleep, like the electroencephalogram, the electrooculogram, the electromyogram, the electrocardiogram, oronasal airflow, the chest wall effort, the snore microphone, the oxyhemoglobin saturation. So here you can see how this polysomnogram, there's so many wires, and these are the leads that are placed all over the system and measure. Now here we can see the obstructive apnea. This red arrow, we can see that the obstructive apnea is a cessation of airflow for at least 10 seconds with a persistent respiratory effort. So here we can see there is 10 seconds of persistent respiratory effort. Central apnea is the cessation of airflow for at least 10 seconds with no respiratory effort. There is no respiratory effort, and the cessation of the airflow is at least 10 seconds or more. But in obstructive apnea, there is a persistent respiratory effort, and cessation of airflow is greater than 10 seconds or more. This is obstructive apnea. In central apnea, there is no respiratory effort. So mixed apnea is an apnea that begins as a central apnea and ends as an obstructive apnea. So in the beginning, there is no respiratory effort, then at the end, there is a respiratory effort. This is a mixed apnea. So split night PSG. What is split night polysomnogram? The patient with a respiratory disturbance index higher than the 40 during the first 2 hours of diagnostic PSG should undergo a split night PSG study. The final portion of the study is used to titrate the continuous positive airway pressure CPAP device. So what are the preoperative investigations? The video endoscopy, the sleep nasoendoscopy, the plus minus video, the polysomnography, the esophageal manometry, the cephalometry and the Mueller's maneuver, the fluoroscopy, the three-dimensional computer tomography, dynamic ultra-fast magnetic resonance imaging and the nasal spray test. So here we can see the dynamic MRI. See. Here we can measure the airway volume and the maximum axial area. Now comes the diagnosis. Well, American Academy of the Sleep Medicine's criteria. The American Academy of the Sleep Medicine criteria. The number A, the excessive daytime sleepiness that is not better explained by other factor. 2 or more of the following that are not better explained by the other factor, like choking during sleep, recurrent awakening, unfractional sleep, daytime fatigue, and impaired concentration. And third is the apnea-hypopneic index, 5 or more obstructed breathing events per hour during sleep. So what is the treatment? The non-surgical measures and the surgical measures. In the non-surgical measures, there is a behavioral method, the weight loss in patients who are obese, and the smokers should avoid smoking, alcoholics should avoid alcohol and avoid supine sleep position. Surgical method is a conventional and the newer recent surgical methods. So what is the nasal CPAP therapy? The most effective treatment for the obstructive sleep apnea is the nasal CPAP therapy. Increases the caliber of the airway in the retropalatal and the retroglossal regions. It increases the lateral dimension of the upper airway and thins the lateral pharyngeal walls, and maintain the upper airway patency during sleep, preventing the soft tissue from collapsing. So this is the most used CPAP is used in obstructive sleep apnea as a non-surgical measure. Here we can see the nasal insert, the nasal mask. So they are different. This is a full mask type. Guidelines for the use of the CPAP. All patients with an apnea-hypopneic index greater than 15 regardless of the symptomatology. Number 1 point. For patients with the AHI of 5 to 14.9, CPAP is indicated if the patient has one of the following. Number 1, excessive daytime sleepiness, hypertension or cardiovascular disease. So without any symptom, is if AHI is greater than 15, then you can use CPAP. Or if it's between 5 to 14.9, but the patient has excessive sleep and sleepiness, hypertension or cardiovascular association, then you can use. So what are the complications and adverse effects? The complications are the sensation of the suffocation and the claustrophobia, difficulty in exhalation, inability to sleep, musculoskeletal chest discomfort, aerophagia, and sinus discomfort. Complication and adverse effect: the pneumothorax and the pneumomediastinum extremely rare. The pneumoencephalus isolated case report, and tympanic membrane rupture, which is very rare. The mask related problem including the skin abrasion, rash, and the conjunctivitis. The nasal problems can include the rhinorrhea, nasal congestion, epistaxis, and nasal or oral dryness. Now the pharmacologic therapy. Modafinil is approved by the US Food and the Drug Administration for use in the patients who have residual daytime sleepiness despite optimal use of the CPAP. Well, the selective serotonin reuptake inhibitor agents such as the paroxetine, which is the Paxil, and the fluoxetine, Prozac, have been shown to increase the genioglosal muscle activity. So these can be used in the pharmacologic therapy: modafinil, paroxetine, and the fluoxetine. Now these are the oral appliances. You can see the mandibular advancement device. which has a soft inner layer rest comfortably against the teeth and gums, and the hard outer shell is durable and resists breakage. Others like the oral appliance like tongue retaining devices you can use. Other is the AVO-TSD. You can see the MRI image shows the AVO-TSD holding the tongue gently forward, preventing the falling back, keeping the airway open, stopping or reducing snoring, and treating obstructive sleep apnea. Here you can see how this device is controlling the falling back of the tongue. Now the AASM recommendations for the surgery. The surgery is indicated in patients who have a specific underlying abnormality that is causing the OSA. Surgery may be indicated if non-invasive medical therapy, nasal CPAP or OA, fails or is rejected, if the patient desires such therapy, or if he or she is medically stable enough to undergo the procedure. If the patient has obstructive sleep apnea that is moderately severe or severe, so respiratory distress index greater than 40 or lowest oxygen hemoglobin saturation less than 80%, the patient requires perioperative airway protection with either the nasal CPAP or tracheostomy. So what are the surgeries for the obstructive sleep apnea? These are the nasal surgeries, septoplasty, sinus surgery, and others. The tonsillectomy if the tonsils are enlarged, and adenoidectomy if the adenoids are enlarged. Ulopalato-pharyngoplasty if there is a falling back of the palate, soft palate. The laser assisted ulopalatoplasty, there is a radiofrequency volumetric tissue reduction, there is a linguoplasty, genioglossus and the higher advancement, sling genioplasty, maxillomandibular advancement, osteotomy, and tracheostomy. Now the laser assisted ulopalatoplasty. This is the OPD, the procedure. So in the laser assisted ulopalatoplasty, what happens in this, the palate trenches are created with a laser and allow to heal by the secondary intention. Scarring occurs and contracts subsequently. So here we can see how the laser is given, and further it scars, and the fibrosis occurs, and scarring occurs, and contraction occurs subsequently. Most study report mark improvement. Here you can see how the before laser treatment and after the laser treatment, there is enough the space now for, and which relieves the obstruction. So what are the benefits of the laser surgery? The laser snoring treatment itself is painless. This can be done under the local anesthesia in OPD settings, and the patient report an immediate reduction in snoring with a progressive improvement. Approximately 85% of the patient's snoring is cured. Now comes the radiofrequency thermal ablation. What happens in this? A radiofrequency device is inserted into the various parts of the palate, tonsils and the tongue base at various thermal energies. There you can see how at the base of the tongue, posterior 1/3, these are the thermal site of tongue base, treatment site of tongue base. So these are the radiofrequency thermal ablation devices are attached. And same way in the palate, hard palate and soft palate. So radiofrequency thermal ablation is another. This is the submucosal delivery of the radiofrequency energy, cessation, the creation of the cognitive lesion, and tissue volume reduction after that. So what is the coblation channeling? It is a new minimally invasive surgical treatment for the snoring. The treatment is performed in office under local anesthesia. Treatment time is about 90 seconds, a fraction of time needed for other radiofrequency techniques. Coblation channeling is a minimally invasive treatment that may result in the less post-operative pain than the traditional surgical snoring therapies. Coblation channeling. Coblation channeling reduces the snoring in two important ways. First, by removing a small amount of tissue via patented process of molecular disintegration. Secondly, by heating tissue to cause a controlled shrinkage and stiffening of the soft palate. So laser snoring therapies involve cutting into the soft palate. With the coblation channeling, there is no cutting, only molecular disintegration and tissue shrinkage. So there is no cutting, only there is disintegration at the molecular level and a tissue shrinkage in coblation channeling. So what is the placement of implants? Now here what happens, see here we can see that the implants are placed in the palate. So insert the needle through the mucosa layer into the muscle, and insertion site should be as close as the junction of the hard and soft palate as possible. So these are inserted as close as the junction of the soft and hard palate. So needles are inserted. Then comes the transoral robotic surgery. What is this? By using the Da Vinci HD robotic surgical system, TORS indicated in which tongue base recognized as a major site of obstruction. Tongue base is recognized as a major site of obstruction. So in that we use the robotic surgery, transoral. So various procedures such as a genioglossus advancement, partial midline glossectomy, hyoid myotomy, and the repose stay suture currently exist to address the region. So TORS offers an additional level of precision to excise the soft tissue of the upper aerodigestive tract, includes endo wrist articulated instrument and the 3D HD camera 0 and 30 degree. This you can see how the transoral robotic surgery is taking place for the Da Vinci. Advances in the robotic assisted surgery. The robotic devices provide a clear high definition view of the surgical field and enables the surgeon to perform delicate procedures with improved precision and enhanced surgical dexterity. Greater precision during the delicate surgical procedure. What are the advantages? So earlier discharge of the hospital, less pain, blood loss and the scarring, quicker return to the normal activities, fewer infection and post-surgical complications. So what is the conclusion? The conclusion is the surgical management provides effective management for the obstructive sleep apnea, can be safely performed in most patients with a proper pre-operative preparation, significant perioperative risk in some patients, and surgery should be considered for the patient unable to utilize a non-surgical management. Thank you.